Hey listeners, did you know this episode of MedSurg Moments is eligible for CE credit? After you listen to the episode, you may claim 0.5 CE hours by following these easy steps. First, log into the AMSN online library at www.library.amsn.org. Then complete the evaluation for the podcast episode and submit to earn your certificate. The Academy of Medical Surgical Nurses is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. There are no relevant financial relationships with ineligible companies for anyone with the ability to control the content of this episode to disclose. Enjoy the episode.
On this episode of MedSurg Moments,
I always give this example of a patient that came in, had low blood pressure, extreme abdominal pain. The blood pressure was so low, the MOA could not obtain the blood pressure, but she immediately let the nurse know. The nurse couldn't obtain the blood pressure, so she went up the chain of command and got our mid-level, who was able to get a blood pressure. So we knew then with the patient's low blood pressure, the order was to give the patient fluids. Gave the patient fluids. They said they were starting to feel better. The blood pressure was still low, but it came up a little bit. The provider ordered x-rays for the patient to go. Patient went upstairs, had the x-rays, came back, and the patient was like, I'm feeling better, I really just want to go. Even though that blood pressure was not where it needed to be, the provider was like, well, we're still waiting on your results, but I guess we'll let you go because I know you've been here for hours. The nurse felt opposite. She's like,
This is Eric,
Mary Tess,
Sydney, Sam,
Neil,
and Laura. Welcome to MedSurg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud MedSurg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
In today's healthcare landscape, the key distinctions and differences between ambulatory and inpatient care, specifically in the oncology world, can shape a patient's journey and impact their overall outcome. But as MedSurg nurses, we can bridge the differences and improve patient outcomes with strong collaboration across care teams.
With us today to explore the key distinction between inpatient and outpatient oncology care, as well as how we can elevate teamwork across settings, is Sandy Page.
Based at the University of Texas Southwestern Medical Center in Dallas, Sandy is a registered nurse with over 12 years of experience in patient care and nursing leadership. Throughout her career, she has demonstrated an incredible ability to lead and motivate healthcare teams to perform at the top of their license, ensuring safe and high-quality patient care. She is currently engaged in a groundbreaking research project using AI to improve symptom management for oncology patients, demonstrating her passion for innovation in healthcare. Sandy, welcome to MedSurg Moments.
thank you everyone for having me. I appreciate being here, and I'm looking forward to having some good conversations.
Before we dive into the conversation, our listeners would love to hear your personal story and what's inspired you to pursue nursing.
I went to nursing school late in my life. I had already started my family, so I was going as a single mom. I worked in healthcare, though, as a financial counselor for many years. And I one day was working where I live now in the city of Midlothian. I was working at an imaging center. And I remember patients would come in all the time and complain about their wait time. And so I thought that I was so smart, and I just knew how the healthcare center should run. And so I did approach our nursing staff and our tech teams. I thought I was very nice and said, hey, we have to do better getting our patients in and out for their well-being. And I remember our charge nurse, she looked at me, and I'll never forget this to this day. She said, Sandy, we appreciate your feedback, but we want you to know sometimes you don't see things on our end. I would recommend that you go back to school and get a degree and maybe look into nursing. In that one moment, I was offended. But I went home and I thought about it. And I was like, you know what? She's right. I went back the next day and I was like, well, are you able to help me get into nursing school? Because I'm a single mom and I don't know the first thing. And to this day, she is my mentor, someone that I look up to. She got me into nursing school. And while I was in nursing school, I ended up taking care of my younger sister who got rare cancer called synovial sarcoma. She ended up on hospice, and this same nurse gave me a book that I needed to read to let me know when it's safe to tell a loved one goodbye. I had great moments with my sister before she passed, and she looked at me because I hadn't graduated nursing school yet. I was just doing prerequisites. She's like, you know what? I think you're going to be an amazing nurse, and that stuck with me. And so for me personally, moving forward in my career, it's just so vital that we give all of our patients and their families respect. They deserve quality. They deserve safety. They deserve innovation. They deserve education. And so to me, it's healing on both parts as caregivers and as our population that we take care of.
Sandy, that's an amazing story. Thank you so much for sharing that with us. What are some key differences between inpatient and outpatient oncology care that can impact the patient experience?
I would say one of the first things that come to my mind would be the way nursing staff practice. So if you have a patient that comes in for whatever reason and they are admitted to the hospital, there are certain aspects of their care that should be documented so that in the event any person on that care team can look and have a vivid picture of that patient's care. I will say one of the barriers, though, with outpatient is that what we document in and what inpatient document in may not necessarily talk to each other. We have something that's called a synopsis, and it quickly shows you, hey, this is the last time this patient was admitted. This is the last time they went to the emergency room. These are their current medications. These are their current surgeries. But you have to be educated to know to add that tab to your Epic channel. And I do not believe they use it inpatient. So a lot of times you get miscommunication between that. And if you think about it from nursing, especially those working inpatient, I don't know what the patient load is, but I'm sure they have several patients and they have several things that are timed that they have to go through. So having to stop and look for something extra just to get the extra bit of piece of information from when a patient, let's say they just got treated on the ambulatory side, but now they're admitted, I could see how that could be a barrier. For me personally, I work with oncology patients, but they get admitted to any type of floor because a lot of times they come in with comorbidities. So let's say they just may be happen to have chest pain that is not related to any treatment. So they may be admitted on a med-surg unit. Well, they're going to want their Mediport access. They're not going to want an IV. And sometimes that could be also a barrier because inpatient nurses may not feel as comfortable placing IVs on patients, especially those patients who have been taking several years of chemotherapy and their veins may not have the best integrity on this. So I do see that a lot. In my career, I've just taken upon myself to say, hey, maybe I can reach out to that manager on that unit, come in, do a quick in-service to show their staff on how to access Mediports. Because people look at it and they're scared, but it's really so simple to do. I actually like them better than PIVs. You just have to keep sterile. So if we keep that the same, I think that would increase patient outcomes too.
Sandy, I can definitely feel your passion, and your story really shares the why, and the way you speak about your specialty right now, it gives me inspiration. There's a lot of collaboration going on, and we really need to bridge that collaboration. So how can healthcare teams improve collaboration between inpatient and outpatient settings to ensure a seamless transition for oncology patients?
I think one of the most important things, as you said, is going to be that communication piece, because not only are they seeing different providers, but they have their nursing staff. You have pharmacy that may be involved. They need to know the patient's history. They need to know patient's weight, be sure that those are entered correctly. There's so many different checks that go behind the scene. If a patient needs to see a nutritionist, They need to know that medical history. They need to know what types of medicines that they're taking to give them a proper diet, or if they need help with chaplain services, social worker services. So for me, I would say what I've seen work is rounding, which I know can be hard with inpatient and outpatient, but I have worked at facilities where the inpatient team meets along with key ambulatory stakeholders, and they literally round outside of each patient's room, and you get a full history, what the patient is on, what's to be expected post-discharge, so that both inpatient and outpatient are kept on the same page. If you are not able to do rounding, I've also seen this work on the ambulatory side. If they have a patient that they know is a cancer patient and this patient is going to be discharged, charge nurses are really, really great at doing SBAR communication to the next charge nurse on the ambulatory to give them a heads up, because they know that we're going to be doing chart workups 2 or 3 days in advance. So if we can learn your patient was admitted here, these are the things that were done, this is the teaching that was done for that patient. And so we want you to know, so when the patient comes in, we can kind of pick that same conversation up with the patient as far as educating and make sure that everyone is on the same page.
It definitely takes a village. We need to work together.
Right.
Sandy, in your experience, how many patients will receive care in both the inpatient and outpatient settings?
We see so many disease processes with our cancer patients. I mean, in any given day, there's like 300 people that come in and out our doors. And so a huge portion of those are shared between inpatient and outpatient. And of course, a lot of our patients still have to go for special procedures. So they're admitted a lot just because of those things like that. So we really try to teach our clinic nurses to really get in the habit of, hey, when you go through your chart, it is an extra step, but you want to look at different encounters that patient has had. So you want to look at trends. You want to know, is my patient being admitted once a week? Because if so, there's a barrier somewhere that we need to catch. Sometimes what they'll do, a patient is admitted, the oncologist may say, hey, give them chemo while they're here, and they may not be translated back to the ambulatory side, which means that they have a pre-existing appointment. They're going to show up for that appointment. So it's so important for nurses to look through the entire chart before proceeding with anything. Because what should happen is, oh, I see Mr. X was admitted. He got chemotherapy, but he's here today, probably because the appointment wasn't canceled, which means that something our scheduling team needs to fix. But you want to be that first one to check and say, oh, wait, let me verify with the provider. We're not going to give this chemotherapy. Then you want to inform pharmacy because they want to do that third check. Like, yep, we're not going to give that chemotherapy. And so we save a patient from getting the extra dose of a medication that they otherwise would not need.
Yeah, I know that can be really dangerous with certain types of chemotherapies and other hazardous drugs that these patients can receive. Besides a lot of this like care coordination that we've been talking about a bit, what other types of challenges do you see when patients move from the outpatient to inpatient settings and back and forth? And how do you think that those could be addressed?
I want to say that the biggest barrier that I have seen is patients keeping up with their medication list. They can be on 20 or 30 medications. And everywhere you go, whether it's ER or inpatient, if you go to radiation, if you go to see your cardiologist, they're all going to ask you that question. And what the provider is supposed to be doing is being sure that we get the most accurate, up-to-date medication for that patient so we can reconcile it in the chart. And what should happen is that no matter where that patient moves within an organization, that updated list is there. And what I found is that sometimes if that's not done correctly, some patients may say, oh, it's right, just check it right. And they may not want to go through, but it's our job as nurses to explain, this is why I'm going through your medications, because it can affect so many things from treatment. And it also communicates to other key providers in that patient's care so that we all can remain on the same page. So patient got discharged, comes in, the med rec should have been done where the nurse goes in before their discharge and verified every medication that they've taken, and then they'll reconcile it. The patient has an appointment next week, so whatever tech gets them as soon as they walk in, it should be that updated medication list that the patient previously had on their inpatient stay. And then that person would just reconcile it and confirm with the patient again. What we have found is sometimes that's not always the case, and certain meds can be contraindicated for treatment for patients. So that's why it's so important to be sure you know exactly what they're taking, the dose that they're taking, and how often that they are taking it, so that you can educate them and compare it to what treatments that they are currently on.
Medication lists are always a hot topic that kind of flare up every once in a while. And I know a key point that we always are trying to hit too is that you want to make sure medications that the patients are prescribed are on there, even if they're not taking them, and then somehow being able to communicate why they're not taking them, right?
Absolutely.
Do they have these adverse side effects that are unfavorable and they're choosing not to take it, or maybe they didn't have access to it, couldn't afford it. So that's been a big heavy hitter for us too when we're talking about medication lists as well. Do any stories come to mind of some good transitions back and forth or any challenging transitions?
We've had good and bad. I'll start with the good. A couple of years ago, our center saw a need for our oncology patients who were having to go to the emergency room because we didn't have after-hour programs. And of course, this was during COVID, so these patients are already immunocompromised. They're having to go sit in the emergency room with an unknown virus that no one knows about. And so what our executive leadership did was they established an acute care center. This center would be open Monday through Friday, 7 to 7. Let's say a patient came in and they were complaining of low blood pressure, fatigue, nausea and vomiting, diarrhea. Then instead of sending them to the emergency room, even if they had the high fever, then they could have an appointment in our acute care center where we would just isolate them. We would test them for COVID, but we would also do labs just to look and see it. Maybe it's just side effects from chemotherapy. Maybe they're in a neutropenic stage, whatever it is. So our goal was to treat them there. And in the event, if they needed to get admitted, we would do direct admissions from our acute care center so that they wouldn't have to go in a lot of open lobbies to wait. So that's something that worked out pretty good.
Sounds like an oncology urgent care.
Yes, that's exactly what it is.
That's so cool.
Surg and Oncology can go hand in hand because a lot of our patients have so many comorbidities. So they're walking in a little sicker. A lot of times it's not their cancer that may cause them to go to an emergency cycle. It could be anything. So that communication between inpatient and outpatient and keeping all providers updated is paramount. Assessment and vital signs. You have to know your normals, and then you have to know when to report and when not to report. And so I always give this example of a patient that came in, had low blood pressure, extreme abdominal pain. The blood pressure was so low, the MOA could not obtain the blood pressure, but she immediately let the nurse know. The nurse couldn't obtain the blood pressure, so she went up the chain of command and got our mid-level, who was able to get a blood pressure. So we knew then with the patient's low blood pressure, the order was to give the patient fluids. Gave the patient fluids. They said they were starting to feel better. The blood pressure was still low, but it came up a little bit. The provider ordered x-rays for the patient to go. Patient went upstairs, had the x-rays, came back, and the patient was like, I'm feeling better, I really just want to go. Even though that blood pressure was not where it needed to be, the provider was like, well, we're still waiting on your results, but I guess we'll let you go because I know you've been here for hours. The nurse felt opposite. She's like, well, the blood pressure isn't where it should be, and I don't feel comfortable discharging the patient. Well, the patient was still discharged. And unfortunately, the result of that did cause harm to this patient. And so what we did as a team, as educators, we took the whole team in. You have to really empower your staff. Like, hey, things happen, but this is the reason when we say, look at the blood pressures, it's a reason why we have created these parameters based on what the evidence says. Because you don't want someone to walk out and then it shoots down, they fall out, they can have a seizure. There's so many things that could happen. So we took it as a learning opportunity. It's just a reminder that don't take shortcuts. Go with that gut, say it. And if you feel like you're not being heard, then you have to escalate it. Because at the end of the day, our duty is to not cause harm to our patient and also to protect our license. So I just try to get in the habit of at least meeting with staff once a month and just kind of remind them like, hey, don't forget your nursing practice. Never take shortcuts. Always put that patient first. Safety, safety, safety. I feel like you can't say that enough.
It's great that your team turned an unfortunate situation into a learning opportunity so that future patients wouldn't have to go through that. I'm sure all these different interactions, especially for oncology patients that they go through, can cause a lot of confusion, not just for the patient, but for the whole healthcare team.
We actually see this a lot now, specific to oncology. We see these patients every day. So I feel we do a pretty good job of teaching from the provider to the pharmacist to frontline staff about their disease state, side effects to expect, and what you should avoid, this type of diet you should eat. And I will say the miscommunication or mistrust does come if that patient, let's say they go to the emergency room, they're seeing an ER doctor, and he may be there for shortness of breath, but he's not an oncologist. And so he may not be able to answer the questions they have according to their cancer diagnosis, which the shortness of breath may not even be related to their cancer diagnosis. It could just be a breast cancer patient, and maybe she's having shortness of breath because maybe she has a lot of anxiety and she just had treatment and we're not giving her any high dose medications. So I've seen that where patients come back and complain, and we tell them, and a really good oncologist would say it too, like, hey, I treat your breast cancer, but he's going to treat your heart. So we're not all going to know everything, but if we all learn to message, that's why it's so important to document, to read it before you go in there with that patient. At least just have some type of background for the patient. But I think just educating them to know that, hey, everyone may not know about your particular disease, but if there's something that's related to a skill that's going to be performed, then that should look the same across the board. So if that patient's there and they're getting their port access, it should look the exact same way if they were going to get it inpatient or outpatient.
And if we're all sticking to the same evidence-based practice, we should see a little bit more consistency.
Absolutely.
And I think another thing that we should definitely do is make sure that the patient understands all of the information that we're giving them. We need to start with asking them, tell me what you understand.
Yes.
So that we're not just assuming that we're being clear.
Right.
We want to hear it from the patient.
Yeah, and that way if something is different, when they go to that other experience, they can advocate for themselves. Like, hey, well, my oncologist told me this, or my nurse does it this way. Are you sure that's right for them? Patients usually know their bodies and their treatments better than anyone.
Yes, absolutely. And that's what we try to do when we teach them, especially walking through something like a port access or dressing change. The nurse should teach the patient, like, hey, this is what it should look like. And this is why I'm doing what I'm doing now, because I don't want to introduce infection to you. This is why I have to sit here and let it dry for 3 minutes. Like, if you just let them know that. And if you go inpatient, it should be the same way.
We've worked on trying to make that a more consistent process to make sure that we're teaching the same thing, we're speaking the same language. Shifting gears a little bit, Sandy, what role do you think palliative care and end-of-life care can play when we're talking about enhancing collaboration between inpatient and outpatient oncology teams?
We have a robust palliative program here on the ambulatory side, and I think that it starts, honestly, with inpatient a lot of times, because most patients, they're not sure where they're going to go. And again, it's just that collaboration, communication against that palliative team, the end-of-life care team, and then all key players that are going to take care of this patient, whether it's nutrition, infusion, is it their med doctor, including palliative care, are we going to focus on pain? What about the spiritual process? So I think inpatient, ambulatory, all together collaborating, and then making sure that we communicate that to the patient and their family in a learning style that fits their needs.
Yeah, helping them really understand what each of those service lines can offer them, because palliative care is not just for the end.
Right.
Palliative care can come from the time of diagnosis. So just making sure that they understand those services are available.
Seems like a lot of information that we can discuss about this topic. But I wanted to ask Sandy, with patients often managing complex symptoms in both inpatient and outpatient settings, how can nursing teams ensure continuity in symptom management practices?
This is actually something I'm working on now with the research study that I'm doing, because there is definitely room for improvement when it comes to symptom management for any type of patient. One of my goals is to create something one symptom at a time where she's empowered to do it. She doesn't necessarily need a physician's order. You take that call from that patient, you triage that call, you document it to a specific smart phrase. So if someone, let's say on the inpatient side, pulled that up, then they could easily read it and see it. Like, okay, this patient called in because they were having mucositis, and she may ask the patient to do gargle and spits, whatever, but follow up and see how that works. So then the person on the inpatient side, that patient were to come in, then they can see, oh, this patient called in from mucositis. This is what the nurse recommended. Or if what the nurse recommended didn't work, this is what the provider ordered. This is what the patient should be taking. And while they're here, maybe I'll do the assessment to see, hey, are your mouth sores doing better? It is complex. There is a lot of work to be done on it. But I think using our evidence-based practice, putting it into an easy format that can be easily read and seen by all team members will help with a lot of standardizing and making sure that patient gets the same information.
I like when you said that it's standardized, but thinking that it's also individualized.
Right.
And very important that we include the patient in all of these because they should be the center of our care. I love that.
Yeah, because symptoms don't always look the same for every patient.
Yeah, and that's true, because they know what's best for them, and we're here to guide them and make sure that we do the evidence-based practice. I look forward to that research. It sounded like a catalog or a protocol. I hate to say a protocol, but it's more of like a catalog
these days.
I know. we don't want to use that, but it's more of like a great innovation for patients, and I can't wait. Maybe it's going to be in an app somewhere.
Abstract, yes. I'm hoping,
Right.
yeah, our poster presentation. I'm pretty excited about it.
That's amazing.
Yeah, I'll be watching for that. I'm excited to see more about that.
And it's cool. I have a team of nurses who volunteers to help. So it's not just me. And we're just going through and reading what the literature says. We have a form that we use so that we can kind of weed out what's appropriate, what's not appropriate. And so our goal is to implement some interventions and see if we can standardize the education portion. So every time a patient comes in and says, hey, I have grade 2 mucositis, there's something that nurse can go and look at, and whatever she hands to that patient is going to be the same that they get, whether they're inpatient or outpatient.
Sandy, have you thought of using AI with that?
Yes. AI is so cool, and it can be used in so many ways. It doesn't replace nursing, but it is a great resource for us. I'm for AI.
I heard you say mucositis 5 times.
Yeah.
And I'm like, if I'm that algorithm, I'll be like, okay, I heard that 5 times already. We're different logics, right? That's awesome. Very, very excited to hear what's going to happen in the future for their project.
Yes, Sandy, thank you so much. I did have one final question that I wanted to ask you to kind of get us wrapped up here at the end. What kind of advice do you have for nurses who are intimidated by the oncology world? It always seemed very overwhelming. The drugs are incredibly hard to say. So what advice do you have for those nurses like me who have been intimidated by the oncology world?
Yeah, I really don't think you should be intimidated. If you've already done med-surg, you're smarter than us anyway. Like, we know this. But
shameless plug for med-surg nurses. Thank you, Sandy.
We love to hire med-surg nurses new to oncology because you see so much and you take care of complex patients anyway. So a lot of it, you're going to see it with oncology patients. I think people get intimidated by the chemo drugs. No one knows how to pronounce all the drugs, but the key is to know where your resources are. So our pharmacy does a wonderful job, and our national organization that we are with oncology does a great job with outlining treatment regimens, common side effects, and how to educate your patients. And so really what I tell new grads or new nurses that are new to oncology, it's just a skill that you're going to learn. Just like with anything else, it takes time. You do have to do a lot of adult learning. So like if you take care of a lung patient, go back and look at their progress report, start the pathology, look at the history. Why is it a grade 2? Why is it stage 4? What do those terms mean? And then when you look at your treatment plan, why is this treatment plan appropriate for the cancer that the patient has. And then you want to use the resources. That's why your providers are there. I'm from an academic learning center, so they love to teach. A lot of our preceptors love to teach, but it's really mostly just having patience and grace yourself, because you're going to pick it up. You're going to know how to take care of that patient in the case of an emergency, or let's say their blood pressure was high or the blood pressure was low or their sats were low, to put oxygen on. The basics. It's just really grouping your diseases into categories and then learning common drills. So you'll never, ever learn all of them, because why? With research, it changes all the time. It's just getting greater and greater, and people are living longer and longer. Most people succeed because they take what they learn in the real setting, and then they do their research on the side to try to put it together. And then, of course, you have the NPD practitioners. We are always here to help people understand their practice and what they're looking at and why behind it. It will always be a team.
Being one of those NPDs, I still have longtime oncology nurses that still come to me with suggestions for things that we can do to help educate some of these newer nurses, because they're still scared and they don't need to be scared. Even those longtime nurses still have questions.
Yes.
Well, thank you so much, Sandy. We are out of time for this episode, but thank you again for sharing all of your time and expertise with us on this episode of MedSurg Moments.
Thank you for having me.
We look forward to connecting with you on the next episode of MedSurg Moments, the AMSN podcast.
In the meantime, we encourage you to subscribe to MedSurg Moments wherever you listen to podcasts.
To reach us, use hashtag MedSurg Moments on your social posts.
Or send us an email at amsnpod@amsn.org. That's amsnpod@amsn.org.
We're all AMSN members, and if you love MedSurg Moments, we invite you to become a member of AMSN. You can learn more at www.amsn.org.
Finally, the content within the MedSurg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, this is Eric,
Laura,
Mary Tess,
Neo,
Sam,
And Sydney. And always remember, MedSurg Moments is a moment in our lives and a moment in our MedSurg careers that makes a huge difference.